the preface to this is that this is kind of whether you're doing football schemes on a chalkboard or basketball, or you're just you're in the drawing room of an old schoolhouse. Is that there is no exact science to this, and what works in one place, others can all the ingredients in New York City. We got Dr. Bacchetta from New York Presbyterian. You can have, he ran a wonderful program up there. He had all the right ingredients, all the components that ran a great program there. And, we in Vanderbilt, we had a program, we have a program now, but just because what cake works in one place and how you baked it, you just can't take that recipe and go somewhere else with it, because it's individual people, it's components, and it's, like we talked about, all the different ingredients to make a great program, whether it be a champion physician, the referral base, what your tolerance of the management is, how many ICUs are you keeping these people in? Is it central located? Is it distributed across all your ICUs within the hospital? There's so many characteristics to an ECMO program that there is not a cookie cutter model. And so it wasn't by design that I picked the chalkboard.
Okay.
So we'll get right into it. So the ECMO staffing models we're going to talk about tonight are perfusion-based, nursing-based, RT-based, and then a hybrid model-based. And the hybrid model is a combination of any and all of the three previous models. And I have experience with all four of them at Vanderbilt. Next slide. So the best way, I just wanted to outline more or less the pros and cons of every model. Once again, this is my interpretation of it. I can assure you, people at Duke, Ms. Belladonna, who gave a great presentation at AMSECT on ECMO staffing. Her experience and interactions with different models is going to be, much different than mine. And I think if you go to any large center, that's doing 50 to 100 ECMO, how they do their staffing model. And once again, it's not to say that they're doing it wrong or you're doing it right, or they're doing it right and you're doing it wrong. It is what your environment allows you to do. And I think everybody's environment is what dictates what is a successful ECMO staffing model where they're at. So the pros in my experience of having perfusion is that you've got the highly trained people. They're specifically trained for extracorporeal support, and so you may or may not need ongoing competency training. I like to say that we have our competency training. If you're an integrated program that does perfusion-based ECMO and you're saying perfusionist or day, every morning you have a wet lab, believe it or not. And so the competency, these quarterly or biannual competencies that a lot of these programs are suggesting, I'm not saying that they're not warranted, but a lot of times, in a large, robust program, they may not be needed. You can also provide your largest patient to FTE ratio. I just think with experience and the control and the comfortability of extracorporeal technology, that's what perfusionists know, and so they generally have a lot more comfortability with managing a larger ratio, in my experience, and then. What goes along with the little to no ongoing competency training is your highest productivity ratio. And we'll talk about what that means in the next couple slides. I'll show you examples of what I'm talking about. The cons of having a specific perfusion-based ECMO model, it's very expensive. Availability of resources. Perfusionists, we are at a kind of a shortage in them. So to utilize and flux up and down With census, it's tough. It depends on what the model you're bringing. But if you're a private practice group, how do you manage for large census in a flu season? Do you hire locum work? That can get expensive.
Yeah, that's a very good. Dude, you brought up some very good points. We're going to be. I can't wait until we get to the discussion part because you just tagged on something that's very tough.
Yeah, and so flu season, when you're for just a hospital-based program, it doesn't matter if you're contractual as a group or you're the hospital-based as you're an employee of the hospital. How do you justify people doubling their number of hours work week during flu season? And with most people being salary, it's tough to manage around that, and so you have to get a little creative with some salary and compensation structures. Once again, you overstaff. Perfusions can't be floated into other service line work. I mean, we all can hold a broom at one point, and there was that's how perfusion got started. It was OJT. It was people that had a knack at some sort of lab work or some anesthesia techs that were pretty crafty, and they got it. And so they just can't float us back into service lines like they used to. The other thing that is kind of a softer side is it's non-OR setting work environment. A lot of perfusionists, they got into perfusion because they didn't have patient interaction. Well, by the time they saw the patient, they were asleep, and when they're done, patient's still asleep. That is not necessarily the case with ECMO. It's a non-OR setting work environment. And there are some characteristics, so there's some interactions, there's some personalities, and there's just interpersonal communications between other subsections of staff that you have to accommodate, and you have to kind of learn how to work with people other than just OR nurses and physicians and anesthesiologists. You have to manage those personalities, and you have to manage where people are coming from a non-traditional, non-perfusion perspective. And then finally, I think this is one of the biggest things. We cannot provide duplicate nursing role. So we can't help the nurse's bedside to give a drug, or if you're not an RN, and not all perfusionists. I wouldn't say that there are some perfusionists that are RN, but mostly perfusion can't provide that kind of role or detail. If the nurse has to leave, to whether give her a lunch break or a regular break, we can't fill that role, and that's one of the downsides of having a perfusion-based ECMO model only. Next slide. So the nursing-based ECMO staffing model, a lot of pros to this. You can get to the one-to-one. To your point, Joe, you talked about earlier, with a certain setup, with certain ECMO circuit design, and with some forethought, you can get that model to where the nurse is taking care of the patient and the circuit. Generally, on the con side of it, there usually has to have at least a 1+ model involved in that. So you have a nurse taking care of the patient and the ECMO circuit. You usually always have to have an additional hand on deck that is just for the designed just for and assigned to the ECMO program. You may have 4, 5, 6, 7, 12, 20 patients on ECMO, and you can have that 1-to-1 ratio, but you still have to have a 1+ model, whether it's giving breaks and lunches or just an extra set of hands in a difficult situation to manage through, whether it's an acute patient that is unstable, or if you have to actually do an intervention onto the circuit or onto the patient. Largest availability of labor pool of the 3 components that we have, whether it be RT, nursing, or perfusion. There are more nurses available to do this and to train into the ECMO specialist role. That is the best thing about this model. It is less expensive than perfusion as far as from a production model per hour, and I want to come back to that. They can be floated in and out into the nursing pool, and we all know that there's a nursing shortage as well. And so it is nice to flex in and flex out with the census of what the ECMO census is in your facility. And then they're already integrated. Most of your ECMO specialists are going to be ICU nurses first, and they're going to be ECMO specialists trained later. And so they already know the ICU. They're fully, they're fully in the waters and how to get things accomplished, which is not exactly what perfusion knows. We have patients that we'll go up and see on balloon pumps or VADs, but we're more versed in the OR than we are in the ICU setting, I would say, in my experience. The cons, ongoing competency training, two parts to this. One, you just have to have a competency checkoff. That's the nursing platform. That's what the nurse educators do, whether it's a CRT machine, a VAD, a balloon pump. They just have competency checkoffs, and that is non-productive time. Non-productive time in a hospital setting is expensive because you're not getting value directly like you do typically in the OR. When a patient's in the OR, there's a click. They're clicking, time, and time is money. In an ongoing competency training, that you have to account for that, and we're going to talk about that a little later. They're not specifically trained for initially. That is kind of a misnomer, I believe. I said, because if you can hold on to the nurse ECMO specialist and you can get them trained up and you can retain them, I think they do a wonderful job. I mean, outstanding job. I can't speak enough to that although I say this is a con, it's in the beginning. Getting someone that didn't go to 2 years of perfusion school or a year of perfusion school to have the background, they're not going to, they're not fully, they don't fully understand fluid dynamics. But I tell you, some of the ECMO specialists that I work with and have worked with, I'll take them in an ECMO setting over a new graduate out of perfusion school, and because you can't replace experience. And so, although I put this on the con side, I just want to preface that. And then this is the one that's hardest for me. It's the con that we run into. It's the options to extend their career opportunities. It's retention. You get good people that are very intelligent people that you offer them a step up off of what their normal daily platform is as an ICU nurse. You go, hey, I think you'd be really good as an ECMO specialist. Let's invest some time, money, because you have the effort, you have the drive, you have the capability of doing this. And then you achieve that. The next thing you know, you have primed them, whether it was you've primed them or they use that as a trampoline to the next step in their career opportunity and their career advancement. So some of them go to CRNA school, some of them go to PA school, some of them go to nurse practitioner school. Some of them go in and get their PhD in nursing. This is just a lot of times it's a platform and a trampoline for their next move, and that's what I've found the hardest thing to manage with this nursing-based ECMO staffing model is the retention is really tough for us, and they are the most expensive to train because perfusionists generally are already trained, and so they're you hit the ground running. 30-day, if you hire someone new, you get a 30-day, orientation, and then you hit the ground running. You've got a nurse that has been an ICU nurse before, but now you're changing their role. And some people they want 100 hours, some people want 400 hours, some people I've heard all over the board. It can take anywhere from 30 days to 6 months to get people trained. And once again, it's also based on your volumes, right? So if you don't have a large census and volume capable of getting the hours, it's tough to get people trained up in a kind of a short time frame if you don't have the ability to do that real time. Having someone sit with a proxy. And we talked about the general need for a 1+ model. So next slide. So the respiratory therapist-based model, this is the model that I'm least familiar with, but we do run it at Vanderbilt on the children's side. There are nurses that are over there, but mainly they're respiratory therapists on the children's side. Retention's much better than nursing, only limited by their degree, because with an RN, BSN, MSN, you can you can go in a multitude of different pathways for career advancement. RT, that's not so much, but also the advancement that you get, whether financial impact from RT to being ECMO Specialist RT, in my experience, has been enough to retain people, and it's a game changer for people, so that they're very, very happy in their career advancement once they hit this level. There is a larger available labor pool, but once again, geographically across the country, we do have some RT staffing shortages as well. Of the 3 staffing models, they're the least expensive labor force to have per productive hour. They can have a limited float capacity, not as much as a nurse, but they are able to float back in more so than a perfusionist. They also are integrated mostly in the ICU environment. They run the vents. They know that environment. They know those waters. They know how to manage the different personalities in the units. Cons on the respiratory side: ongoing competency, very similar to what we talked about in nursing. Once again, not trained specifically for ECMO support. Very similar to nursing. Similar to the perfusion role, they can't provide a duplicate nursing role either. They can't give meds. They can't step in for the nurse for a break or a lunch. They have smaller into FTOs, and they do a one-to-one in other models that I've known, whether it be Duke or other facilities, UAB that use respiratory therapists. Their ratios are smaller than for nursing and for perfusion as far as their staffing ratios. Once again, we talked about they're expensive to train, and once again, generally need a 1+ model. That we talked about, that they're very similar to the nursing staffing model. Next slide. And then you've got your hybrid brace model. I think I heard an excellent talk at AMSEC about their hybrid-based ECMO staff. We ran a little bit of this at Vanderbilt because of some of the things we'll talk about later in the final closing slide. We've gone away from the hybrid staffing model, but you can flex disciplines to accommodate your census, especially acuity census, right? So you more or less what I like to call, you put the right people in the right place to succeed, and for the patient to succeed as well. And so you can run different ratios. You can put people in one-to-one scenarios to accommodate the acuity that's needed. It brings in all aspects, so it is the largest available labor pool of all the models because it's combined, right? It's A plus B plus C availability. It can be the least expensive model if you can retain people. We've seen that. You do have the ability to float people back in and out because you have multiple different cohorts of people. If you have low staffing model and you have one perfusionist that's on your team, if you have a 1 perfusionist, 2 nursing, 3 respiratory therapy model, and you only have 1 patient on, well, it's easy to float, 5 RNs and respiratory therapists back into the model. And you've really lowered your fixed cost for that particular shift. And once again, I talked about the acuity and the flexibility of the staffing. Cons: ongoing competency. The problem with this is that when you do a hybrid model, you have to lay the groundwork down that where every single cohort of every discipline has to do the same competency. Because you can't distinguish between one group and another group because you are a team, and so everybody does that competency. That raises the cost of the program because now you've got all groups, including perfusion, into that competency training, and that you just have to have that. You can't just say, well, perfusion, you do this every day. No, when you're a team, you're a team, and that's the team. That's the right thing to do as far as dynamics. We don't ever want to put anybody above anybody else when it comes to the roles, regardless of their background. Cannot always provide the duplicate nursing role, but once again, I'm going to put this on the con side, but general staff coverage your specific patient acuity and volumes. I think more so than not, You can't always do it, but at times, and if you have a little more forethought with it, you can do it depending on what kind of schedule you run and what kind of staffing model you run. Very flexible and efficient patient to FTE ratios. Like I said, it goes right into that's a con. I apologize. That should be on the pro side. That's my mistake. It's very flexible, very efficient. That should be on the left side, right below the last one on the pro. But it can be the most expensive model as well, based on your retention, because once again, your retention plus your competency training is where that's where it's going to get really expensive for you. You have to be able to manage those two. And then, regardless what you do, you have multiple different backgrounds, multiple different work experience, personality, and just knowledge base, right? You have respiratory therapists that know the ventilators. They know the ventilation aspect of ECMO. They have nurses. They know patient care. And then you have perfusionists. They know perfusion and pump. So when you look at it from a standpoint, when you step back, each cohort has a leg up on the other two, regardless of what you're looking at. They have the experience, the knowledge, and the background on a leg up on the other two. If you're just looking from a general background standpoint. And it's very it can be very difficult to manage the personalities of bringing three different team members that can have a difference of opinions on the same team. Next slide. And then finally, the overall considerations and tenets of ECMO staffing. Your patient sensitive values are critical in picking a staffing model. That's once again. That is your custom. What kind of cake are you baking in your institution? What are your needs? And you have to have your projections. And I kind of lay this on the at the feet of the administrators and the physicians. Of what are we trying to? What you should have a business model, a 1, 3, and 5 year outlook before you start an ECMO program. What are you looking to become? Who do you want to be? What kind of center do you want to be? And what kind of facility, are you wanting to hold on to ECMO patients for 24 to 48 to 72 hours? Are you wanting to hold on to them for a week? Do you have the VAD capability, the transplant? Do you have the transplant capability in your facility? Or are you going to handpick, during flu season, the people that you're going to do VV? Do you have what are you going to do, and what can you do? That's kind of the background. The initial training of non-perfusion staffing, it's roughly $20,000 per FTE. It doesn't matter where you're at. Mayo Clinic wrote a paper 2 or 3 years ago that's the cost. It's $20,000 per FTE to get trained. Doesn't matter the background of nursing or RT. It's $20,000 to train them from whatever as a current employee to adjust them to an ECMO specialist. With ongoing competencies, there's between 15 and 25% of loss, meaning that non-productive hours. So if you've got a full-time FTE of 2,000 hours a year, you can count on only that person providing between 1,500 and 1,700 hours of ECMO of their 2,000 hours that you pay them. Those are actual numbers, and we track that. We track that on both sides of at Vanderbilt, on the children's side and the adult side. And once again, going back to the first thing, coverage is 24/7, 365. Even when there's no patient on ECMO, if you're an ECMO facility, what are you? Are you someone that we're going to cannulate emergently? Are you going to do ECPR? Because if you do ECPR, that's a game changer. Because that means you have to have, when you have no one ECMO, you still are paying for someone to be able to provide ECMO services when you have no one in-house. And that is costly. I can tell you if you are going to do ECPR and you're going to have someone in-house 24/7 available, it's between $500,000 and $800,000. That's just the cost of doing that. And if you have one, and that's a fixed cost. That's now if you do, you're going to go ahead and be able to retain and reduce some of that cost, because you're going to actually have the patients to offset that. But you're out between $500,000 and $750,000 if you're going to be an ECR program. And then finally, I hear this across the country. Anybody I talk to about it, retention is the single most important variable in ECMO staffing model. It doesn't matter what you do. The retention is your it's your Achilles heel. If you have good retention, you have good results, you have a financially efficient program, and you have a program that has really good outcomes. If you have a revolving door of of people that are taking care of your patients, it's expensive. The results are less than ideal, and you're always putting your thumb in a dike, and you're trying to just hold it together. And that's really the number one model. And so I think when people go to look whether they're going to open an ECMO program, they really need to look hard at what ECMO staffing model they're going to have. And then based on what that staffing model is are you going to be able to retain those people, or are you going to have a revolving door of that same type of person? If you're going to do a perfusion-based model, do you have the retention of your perfusion staff? You're going to do a nursing model. Can you retain your nurses? RT model. Do you have enough RTs? Can you ramp up and ramp down with volume? Or for a hybrid model, a hybrid model is not without its a cost of retention, because it doesn't matter what cohort you're using. If you can't retain that particular cohort, it's still going to get expensive. So that's what I got, Joe.
Okay. So we'll go ahead and you brought up something which was that really got my attention, and that was how does a private group, and since you're now in our group, good luck. How do you manage when there is the flu season, or ECMO volume goes up, or it goes in Christmas Eve at 3 different hospitals? So yes, there are several aspects to that we have thus far successfully been able to manage. And it's real interesting. I'll tell you this. This is a true story. I had to do a dog and pony show for a hospital here recently, Kara. And someone was in the meeting as well after the dog. And there were like 3 of us, 3 different groups, not all at the same time, but one after another, that had to do this dog and pony show to talk about your value to the hospital and why they should either retain you as a group or change and go to another group. And one of the people asked this other group, well, what would you do if there was a heart going on, a patient on ECMO in the ICU, and an emergency heart came in and had to go to another room right now? And the response was, well, that's kind of a perfect storm you're talking about there. They were like, but that happens all the time, So, I mean, can you handle that or not? It's either yes or it's no. What are you going to do? Well, we're going to have to tell you that you can't do the case, was the answer. Well, that didn't do well. All right. I've, knock on wood, whatever, in all the time we've been here, it's 10 years now, we have not once yet not been able to cover something that occurred. And I'm really very proud of that. But I will tell you that it gives me anxiety. I don't sleep well at night. I worry constantly. And because this is the reality, this is the paradigm of our environment here in Houston, we are always one person more than we actually need. If you go back and look at all of our numbers, we have peaks and valleys and volume up and volume down, but we basically take the worst possible situation and say we have to have at least one person for all of that and this too. And all of that's a formula based on the number of surgeons that we have, how many do what hospitals. We look at all the previous volumes. Now, our group is salaried. So as an employer, we take the good with the bad. And the employees, because they're happy, I think the team members really versus employees, they're happy. They think they know that we as a group care about each other, and people are always willing to help out and pitch in. We do have to depend on some per diem, and we use them whenever possible. But when we have low census, well, let's first say when we have high census, high acuity, a lot of ECMO, a lot of cases going on, everybody just pitches in and gets the work done. Mm-hmm. When it drops off, which it always does, especially the dog days of summer, and there's nothing going on, nobody has to take their vacation time. Nobody has to be flexed off. You know, you can take your vacation time or day without pay or whatever it is. And that's where I think hospitals go wrong. Mm-hmm. They want their cake and eat it too. Now, you come from a model that was hospital. Yes. So you worked for a private group, then you worked for a hospital, now you work for a private group again. Mm-hmm. So private groups can manage it, but they have to do either one of two things or a combination of both. You either have to accept a lower profit margin, you have to operate more efficiently by not having a very top-heavy organization with a bunch of managers that do nothing, and the few people doing all of the work and the revolving door that you see in a lot of these big perfusion groups, and we all know that happens, or a combination of both. And I think that, again, not trying to be perhaps a little self-serving or self-promoting, but I think that as a group, we've kind of come up with that. We used to use Tammy as a per diem person and several others. We have good relationships in the city. We try not going in and, for lack of perhaps a more eloquent way to say it, we try not to go peeing in people's cornflakes so that we have good relationships with other outside facilities so that we can have that collegial help each other out relationship. If anybody needed it, we don't go there and try to mess up their thing. And in return, we have good relationships. They come and help us. We pay well and we get through our circumstance. So, rather than having our call people in the hospital all night and working, we try to use per diem as much as possible. And just try to make the work environment as humane as we can. On the rare occasion when there's just nothing else you can do besides having to do a couple of days of inhumane misery, working your tail off and never getting a break except to, get a little bit of sleep. The people that work with us, genuinely, they do it. They may not do it with a big smile, like, oh, this is great. I get my weekend's completely ruined. But they do it willingly because they know that other people will do it too, will help them, and that there's somewhere along the way it evens itself out. And it's all about relationships, and it's all about caring about people. I mean, it's all about being fair as you can be. And I think that a private group has more of an opportunity to do that than a big institution. Anyway, there's my kind of, threw it all out there and just said it. What do you think?
Well, I think you're right.
Oh, good. You. Anybody.
I think in a hospital setting, they are definitely looking at productive hours, even for perfusionists, and they're looking often at the numbers. And sometimes the numbers work in your favor, and sometimes they don't. And as you know, people have to take vacation. Sometimes people have emergencies, and hospitals don't always factor into that. They're looking at, I have this many number of hearts or whatever else you're doing, cell savers and things, and I only need this many perfusionists for that. And not always accounting for, the the rise of when you're going to have a bad season, or you get an ECMO and you're not really an ECMO center, so you're not staffed for that. The cases are still being posted in the OR, and you're still having to watch those ECMOs, especially if the hospital is not on board with having relationships with perfusionists outside of their system. You can't get people in to help you because they're not credentialed, or
that's a great point, because Matt, it's very expensive for us as a group, but we burden the expense to make sure we pay for the credentialing of all of these per diem people, to so that it's not their burden. We burden that expense, and hospitals don't want to do that.
No, they
because you never know when you're actually going to need them, if ever, and they don't want to spend the money to make sure that they can fill that gap. And then you guys we were a relatively small department, and they didn't care that you were up all night. So you were up all night, you were on call, now go do the case.
That's right.
And there's not this concern about them as being people. And that's,
I think the hospital situation can be very difficult to manage if you're not an extremely large program, because then you've got a big team and you can absorb some of that. Or you're a really small program, so you're not going to keep that ECMO, or that you only have your one surgeon that's doing the cases. If you're kind of a medium-sized program, you can't really have a big staff, but you are going to have those influxes of, doubling your hearts in a month sometimes, and you have an ECMO on top of that.
You can't get a patient off pump. It doesn't even have to be a VV.
Right.
It can just be you can't get this patient off pump, and they're 52 years old, and this was a simple 2-vessel CABG, and oh hell, we can't let them die, and there's an ECMO.
Right.
Which could go for quite a while.
Right. And, do you have any kind of relationships with an ECMO center that's going to take your patient? If you don't have those established, but you are doing some ECMOs, then that's another problem.
And then what if they have a bed?
Right.
What if they don't have a bed for the patient? Now what? Okay, so we'd love to take your patient, but we can't. We're full. In fact, during the H1N1, they were diverting from the med center to us. It's at where? Yeah, I can't say the place.
In the community hospitals.
Yes.
Yeah. So, I think the model of staffing, it has to be looked at from all perspectives. And, a hospital model staffing just they have to have, I understand you can't staff people, pay them when you don't really need them. But maybe there's some kind of other model that they are going to have to incorporate, having permanent per diem staff that they, guarantee so many hours a year, but then also they can be there to help them have that flexibility when they have those higher caseloads. Matt, do you have something?
So you make a great point. I recently just had we have a relationship with a community hospital that's 4 or 5 hours away from us. We took probably 10 or 15 of their ECMO patients the last 15 years. Or I'm sorry, 10 or 15 of their ECMO patients the last 2 to 3 years. And they're starting to get they're really good at patient selection. They're really good at getting the patients on in a timely manner as far as the window of opportunity. And also they say, well, we may want to do this. We may want to go through this route, but they don't want to go all in yet because the nursing and the nursing model and the RT model is a little expensive. What they wanted to do is they wanted to expand on some of their perfusion staffing, and they were going to extend it. And so it's a large perfusion company contract group that's in there, and they've done an a la carte service that what an 8-hour ECMO shift looks like. You have 2 or 3 people, or actually they have 3 or 4 people in that facility. You talk about a medium-sized program. They're doing between 500 and 600 hearts a year. It's a nice program. You have one patient or one person goes out of town for a national meeting. You have one person go out on a death in the family, and then you get an ECMO patient that week. The next thing you know, you've got someone that needs an emergency surgery on a Saturday. Routine surgery. Well, you don't have anybody available right now. So what you do is send that patient across town to one of your competitors, your hospital, a hospital that is now, instead of you doing 502 cases that you're done 501, and the other patient now, or the other hospital that case. And we all know that you want to make sure that you're managing your referral practitioners, right? Mm-hmm. Your docs. So when you actually are going to try to do something that you're not really sure that you're good at, like you're going to go ahead and take these ECMO patients, you're going to hold on to them for a little while, and then you're starting to turn away business that you're good at, that will raise some eyebrows in the administrator's offices. Why did we turn away an emergent cabbage that we know we're good at? Because we're holding on to an ECMO patient because we think we want to get good at that. Mm-hmm. So that will change the dynamics.
Yes.
Absolutely.
Well, Matt, I need you to go down to that place, and I need you to give them my number, because it doesn't matter if the other perfusionist was on vacation or a meeting and the death occurred. Again, we have never not been able to cover it. So we can cover it. So give them my number. Okay?
Yep.
That might get some, don't really do it, but you can do it if you want to. All right? It'd be nice.
I think your joke brings up a fine point about when you are a contract.
Yes.
Not seeking out contracts that you can't cover.
Very good.
We know that there are groups out there that do that. They promise to be able to do these things, but they really don't have the staff for it, because they really don't want to staff for that rainy day. They want to staff for what they think is going to happen. Mm-hmm. And I think that's where a lot of institutions get a little bit leery of using contract groups, because they've heard of situations like that. But
at the same time, and that's a very good point you bring up. That's an excellent point. In fact, because what they say is, and I've been doing this a while. I've heard all the stories. I've had the proposals given to me too. Because we're all over the nation, and well, if we need to bring somebody in. What happened to Matt? Where'd he go?
I don't know.
I'm right here.
Oh, there you go. Okay, you came back. Yeah, you went dead blank for a while. But okay, and we could have somebody here in 12 hours, but they don't have a license in the state.
They're not credentialed
at the hospital. Oh, we'll just get them emergency privileges. Well, it's just, and I think the local or the regional perfusion groups are much better equipped at managing these things than these big, large groups. I think these big, large groups have some utility, but I think that's one of their Achilles heels, is that they are stretched way too thin, and they overpromise and underdeliver all of the time. And they're so big, they can get away with it. I can tell you this is how I feel. If I have an account, I feel that it is my responsibility to cover whatever comes through that door. That's not their responsibility to say, well, Joe, we're really sorry. We understand, you just don't have the personnel to do it. I've agreed to handle whatever they are capable of doing. Now, if there was a catastrophic event, but even during Hurricane Harvey, we covered all of our hospitals in Hurricane Harvey. Our group did, with no deficiencies. The other groups couldn't do that, and they didn't. And I do, and I am proud of that. I'm maybe being a little bloviating tonight, but I hope you all forgive me for it. But I'm doing it. My show, I can do what I want, right? But no, I think that is a problem, Matt, and Tammy, that people will promise something, and then when the rubber hits the road, they can't deliver. They talk the talk, don't walk the walk.
I agree.
But I think a hybrid program is a good way to go. I do think that, it may be a little more expensive to train the nurses than perfusionists, but instead of, for example, having a perfusionist sitting at the bedside monitoring the ECMO all night. You have the nurses trained. You have a good relationship with the hospital. The perfusionist could perhaps be in-house, but sleeping and available in case there's an emergency. And if they get called, they can get up and they can go take care of that problem. But they're getting sleep throughout the night and not being up and then having to also function the next day or be out of your system the next day. So that might be a potential hybrid model that might work for some places.
Well, that's a good point too, Joe, as well, because most nurses and RTs, they're either night or they're days. They usually don't flip back and forth too often. But perfusionists, by nature, we're not night or days. We're not weekends or weekday people. We're whenever it comes. And that is one of the hardest things about our job when it comes to involving ECMO, is that we have to have the ability to fluctuate between day and night and recover, relatively soon. And it really works. It really, I think that's the hardest aspect of the job when it comes to perfusion.
And then compensating people. That's yet another whole
That's a whole other talk.
Kara, you have any thoughts on this? You have staffing issues because you may not have ECMO staffing issues, but you have operating room staffing issues.
Sure.
And you have rooms that need to be covered and people that may have called in sick or called off for whatever the reason may be. What do you do?
Well, some of us are used to kind of float. So I'm an RN. So even though I moved into the education side, I'm perfectly capable of staffing a room, which I'm happy to do and keep up my own skills. But sometimes the beauty of being a nurse is you can wear so many hats, especially in certain areas. But
and that is an advantage, I think.
Huge advantage.
Much more so than
I can be an
perfusion.
educator one day. I can be a charge nurse the next day. I can be your CVOR nurse today. I can scrub a few cases if I need to. But, you always seem to make it work. But when you throw those human factors in of family emergencies, someone calls in sick at the same time, they don't want a lot of extra staff, FTEs. Productivity is always number one on hospitals' radars, especially in the given day and payer mix and how things are in the system. And I
think a lot of times though hospitals are penny wise, pound foolish. Does your staff, and Matt, do you in your perfusion department, but in your previous employment, I'll kind of go around the room. We'll start with Kara. If there are no cases, are people required to take the day off? Do they get told, we're calling you off tomorrow, and if you want to be paid for it, you have to take it as a PTO day?
Sometimes, not all the time. And usually, usually there's people, what they do is the volunteers first. And usually when you're dealing with these amounts of staff, 30, 40 people or whatever, there's usually one or two people that are like, I'd like the day off. It's not a problem. But when times get a little, thinner and things get that, they do it on a rotating basis, or, they take turns. So they try to rotate through the staff. But, that's a staff satisfaction thing. And it kind of makes people upset when they're using their PTO time or vacation time to make a full paycheck, so that's always kind of a sore subject with staff and departments, or you're still going to be on call, we're going to work you all night, maybe all weekend, but then come Thursday or Friday, if we don't need you, we're going to send you home. And
then you lose your overtime because it's not 40 hours in the week.
That right there,
that would make me very
really
angry.
Rubs people the wrong way.
Did they do that with your perfusion department in your previous place?
They tried to do that. We found a workaround. We picked up other things to do. We made sure that we documented what they called non-productive hours, but things that needed to get done, whether we took on helping with training on point of care devices, or we're helping with doing a restocking of inventory or things like that. We found a way around it so that it kind of just went away. But they did want to do flexing off.
And the nice part about that is then they can usually appropriate to different cost centers. So that usually helps even out.
Exactly.
It's all about playing with the numbers. Matt, what about you in Nashville? Does your department require that?
No, we've come up with a relatively unique compensation model, and so our compensation model is that we're anywhere between 3 and 4 FTE short of what our FTE status is, and that's by design. So we don't run into that scenario, and then we have a salary plus bonus for productive hours, and so we've always and it works well. Because throughout an entire group of 10, 11 people, you always have a bell curve of people of where they're at in any part of their life, and life changes, right? Mm-hmm. And so someone that was relatively single with no kids 4 years ago, and we were running this department the same way. 4 years later, they're married with born. We've got someone, potentially that is now an empty nester. Their kids have moved on to college. And so, everybody's lives change and they have different needs at different times. And so the availability of having that flexible of what you want, you can work as much as you want because we are understaffed. We're understaffed and we do it purposefully, but we always have to staff for what you would call is that we only allow so many people off at any given time, and knowing that everybody has the capability of working a 6-day every single day that they're not off on vacation. And so you have to have it, like Joe said, the hospital wants it their cake and eat it too. This has been one of the best scenarios. We are hospital based, but we are run like a private group. And the hospital, it's a win-win for the hospital as well.
Yeah, absolutely. I think that model sounds like it worked great, but you have to be in a program that has a larger team.
Enough people that can pick up that want to do that. So on your bell curve, you have to have enough of these people to do that. I'm the exact opposite of you. So it's really interesting for me to hear that. Do you mind if I just ask you a question? And I promise I won't ask too many more questions, but what is the average number of hours a person in your group work? So we do. So our productivity model has to do with patient care hours, and then there's a call component, and then we call it a 1+. We call it the bubble. Because if you've got 2 people working, that third person, although they don't have to be in the hospital, they have to be within a 30-minute call range of the hospital because they have to be available, right? Right. So there's 3 different ways you actually get compensated. You get credit towards your overall productivity score. So direct patient care hours are a 1-to-1. Your call hours are a very insignificant portion because call hours aren't really productive for the hospital, so they're not real inclined to want to pay for that. But your one-off model, what I want to call the bubble time, our bubble time is the same as whether we have the same as if we're doing patient care, because what we did is we said you can have the call pay. We've given part of that back, saying that we want very little call pay at all. But what we want to do is we always want to have that 1+ model. So when we have 2 things going, we have 3 people collecting at a primary rate. If you can imagine that. Yes. And our call pay is really nothing. I mean it's I can give you the example. It's $100 for the entire week per person. I mean, that's horrible. I wouldn't even tell anybody that. That's horrible. Well, I mean, but it is. But the offset.
I mean, I was going to follow up with we don't get paid for any call.
You don't get paid for any call.
I'll take the $100.
Nurses, it's usually like $3 an hour.
Well, so let me ask you.
It's part of the model. It's part of the model. So, but getting back to your point, how many hours? So we have between 40 and 50 hours of patient care interaction per week.
40 to 50 hours of, so not the bubble. We're talking actually in the hospital taking care of the patient.
Correct. We have between 40 and 50 hours. Now, that's what our all 11 people do on an average. I mean, and of course, we've got people that are up in the 60s, and we've got people that are down in the low 30s. But that's the average. And with that model, if that's what works for us.
Okay, good. So what about where you used to be? How many hours per week were you physically? First of all, were you required to be there 40 hours?
No.
No. Okay, that's good.
We were required to cover the cases and make sure someone was available, between the set hours of normal operating hours, whether that's 7 to 3 or 7 to 5, kind of just depends on which administrator was in charge at the time. But we were able to, stagger staffing in if there aren't cases, or, early leaves when they're, things finish up early. But being a small team, we only had, one person on call. And as you know, that works when there's only one emergency or there's nothing running late. So we always had to have the kind of understanding that if more things happen and you were not coming in yet, or you've already gone, you're going to have to come back. And being a small team, it kind of worked simply because you knew the other person was going to have to do it for you at some point. So.
Right. Absolutely. Yeah. And then in nursing, you're required to be there. There's no such thing as, you're working, but you're not physically in the hospital. Or is there?
You mean for call?
For anything.
Well, I mean, if your shift.
You have to clock in.
Right. Most nurses are not salary. If you are, you're in a management or administrative type of role. So you're there working. So obviously anything above and beyond. And then also call pay is very minimal, but you get paid to be on call. It ranges anywhere from $250 an hour to maybe $350 an hour, depending on where you're at. And in extreme cases, sometimes they'll even ask nurses to change their shifts, flex kind of when they're coming in to meet the demands of the unit at the time, or as things change. And there's always opportunities to pick up extra shifts or cover, or ask for volunteers to come in. And there's always people that want the extra hour, so it usually works itself out as well.
Right. Well, Matt, okay, I'm being told by the technical staff that our time has come to an end. Matt, once again, I want to thank you so much for just a great series of, really great series of talks. You are very, very knowledgeable on the subject of both ECMO and certainly perfusion department economics, if not also just hospital economics. You've really given me at least a lot of things to think about, and I think the same applies for our panel and those watching us out in the web world and who will watch this at some later date. So we want to thank you so much for that, and I also want to thank Tammy. I want to thank Kara, both for being here, and Caston, her son, who's running around out there somewhere, probably eating, and we're all starving too. Hopefully you are too, Matt. You can get home. But thank you for just your generous time. We can't, this kind of thing is so important, and it brings such a great value to our profession for us to have this out there in the web, and also for our colleagues to see, and for even others to see, to know that what we're all about and what we're actually doing. I asked one time, I had a little table and I had a little jar, and I said that I would give somebody, you would get $1 if you could tell me what a perfusionist was. So people would come up and it would just say, win $1. And people would walk up and I would say, what's a perfusionist? And I tell you what, I made perfume. You played music, no one ever, the only person that ever got it was, I was standing in the hallway at Memorial Hermann TMC. I got thrown out of the hospital too for this. I don't know why they got upset, but I had a camera set up and doing the same thing. These are people in lab coats that didn't know what a perfusionist was, but one veterinarian happened to know, so he won the $1. And then the security came and said, who the hell are you? And you need to get your stuff and get out of here. So I got tossed out. All right. Thanks again very much. We'll see you all tomorrow morning. Matt, you won't be with us again. You're always welcome to join if you'd like, though. You can always check in with us. And I'll be calling you again pretty soon to talk about some of the other stuff that we're doing with the Tennessee Perfusion Society. You're the past president, right? and you've got your big meeting coming up. And we need to start advertising that. You know, we've been talking about that for a while. We need to get that done. And
October 5th.
Huh?
It's October 5th.
October 5th. So you need to call. We need to get that online and get that going. Have a safe trip home, everybody, and we'll see everybody that's going to be watching the program tomorrow morning back here at 9 something or other. So check online on perfweb.us and you'll find out about it. Good night, everybody. Good night, Matt.
Good night.
Tammy, Kara.
Thanks, Joe.